thought one of the topics was that we talked about earlier was asynchrony. And I'm just question for the panel members about, do you think asynchrony, I mean, the question is it bad or is it just a marker of a sicker patient? And I guess then I'd like to hear it tied in with the hemodynamics. Do you think that asynchrony and hemodynamics, maybe that's a mechanism for the poorer outcome? I don't know, you're shaking your head. Do you want to start to take that?
Yeah, I think that as long as acute cardiovascular problems are concerned, asynchrony is an extremely important issue. I mean, we see very often in patients with various causes of acute circulatory failure, once they are dyspneic, spontaneously breathing, and you intubate them, you will see a fairly dramatic improvement in their status. Now, that is, as I said, regardless of the pathophysiology, because normally you have either you have a right heart problem or you have a left heart problem, and if you are able to manage them without crashing the right ventricle because of too high pressures, you will be able to attenuate the adverse impacts of dyspneic breathing. So yes, I think it is an important issue. I mean, it is in the switch from spontaneous to positive pressure breathing, and especially during the positive pressure breathing, if you see a severe asynchrony during the breathing, you can most likely also detect very clear adverse cardiocirculatory effects. So in fact, we used in our trial as a criterion to select our patients that we saw these huge intrathoracic pressure swings to consider the patient as candidate for the heart and lung interaction study.
Erika, do you want to comment on in infants?
Well, I think that asynchrony in infants, it's the question for the need for sedation, because in general, children do not tolerate the invasive ventilation as well as adults, and they need much sedation. And if we can improve the synchrony, maybe we will be able to decrease the amount of sedation used.
That's the key there. Questions? Do you want to comment?
Well, I just wanted to say that in terms of asynchrony, if we talk about the off-cycling asynchrony, so ventilating the patient within his expiratory phase with positive pressure, that's what actually causes the impedance for the right ventricle to increase, so which probably impairs the outflow for the right ventricle. But on the other hand, I think we always have to keep in mind there are other factors. For example, CO2. If CO2 increases, this is harmful for the right ventricle as well, because it just increases the pulmonary pressure by vasoconstriction. So it's a trade-off. It's not always beneficial to maintain spontaneous breathing for all costs. All we can do is just trial and error, monitor the patient and be very careful and try to maintain physiology. But if it doesn't work, maybe controlled mode of breathing is even better for a specific type of patient, because other factors are relevant as well.
Sure, if you increase the work of breathing tremendously, the oxygen cost of breathing,
absolutely,
you're not doing much in favor. Krister?
I'm just, since we have the expertise of cardiovascular here and cardiopulmonary function, is the asynchronous we talk about. I mean, there's two ways we could see it, but one is that you either start with an occluded effort, so you create a huge negative swing, and then after that you get this instant pressure increase that just goes straight up. The other one is that you do like that effort, but how do you say that? The other one is that the ventilator persists like over the breath. And what's the effect of these kind of wall-to-wall pressures? I mean, you can go -10 and then you're +20. Like, is there, because the heart rate would be, say, 60, 70. The respiratory rate in an adult would be half of that. In an infant, the heart rate would be, say, 120, the respiratory rate 60. So this happens all the time.
Well, I think there are several issues. One is the direct impact of these major pressure swings within the intrathoracic circulation and the function of the heart itself. That's one part. The other part is extrathoracic impacts. I have anecdotally in performing hepatic venous catheterizations in a trial for dyspneic patients, I've seen intermittent flow across the splanchnic bed during severe dyspnea. So I mean, it's depending on the magnitude and also on the cycling of the swings that will determine the net effect. So there is no way to say that, you know, this kind of pressure will have that effect, because there is also the impact of the timing. That was one of the reasons why we chose this cycling, this cycling quantification using the vector, in order to see how does the pressure swing through the breathing cycle behave. But it's clearly, it is an area where we have just scratched the surface.
But would it be ethically defendable if we would say design a study as we can do in animals, where we would deliberately cause asynchrony in these patients in order to see what the effect would be? I think no, but
I mean, in patients certainly not, but I mean in the animal lab, I think it's something. That's,
yeah, but I mean, it's so the effects are pretty severe, and you would not like to bring.
They can be pretty severe. Yes.
Theo?
Yeah, I think that we should also think about the effects of asynchrony on the respiratory muscles. Not proven yet in humans, and not even in animal models, but the respiratory muscles
Wait,
are
not
skeletal.
in humans, not in animals? What then?
Well. They are
In
skeletal
amoeba.
muscles. Usually physiologists apply knowledge from peripheral skeletal muscle into the respiratory muscles, and then they become famous. Okay? So if you go to the gym and you do weightlifting, by the time that you start your biceps contracting while it is increasing, extending, when you leave the weight down, you can have eccentric contraction, which is injurious for the muscle. Next day you feel ache, and your muscle force goes down. So if we're doing an inspiratory effort during expiration or the reverse, theory predicts that we could injure the muscles, and this probably makes a link between the prolonged duration of weaning observed in patients that have frequent ineffective efforts and asynchrony. So asynchrony is not only the patient is fighting the ventilator in front of us, probably he is injured or she is injuring the respiratory muscles while fighting the ventilator. We should keep that in mind, I think. And
Is there any data on that, Theo, even in animals? I mean, I understand the theory, but...
There is some indirect data. They have done measurement of contraction, of regional contraction of the diaphragm with small monitorings, and they have seen that when you have ineffective efforts or occluded contractions, then you have at some places of the diaphragm extensions while the rest of the diaphragm is contracting, which is a very, very indirect evidence of injurious ineffective efforts. I mean,
there is.
very indirect.
We did a study in Montreal many years ago. It got published in Spanish for some reason. But it was actually, we used a plunger to actually extend the diaphragm by increasing the abdominal pressure, have a casted abdomen and chest, and had the diaphragm moving the wrong way while the animal was breathing in. And that caused severe injury of the diaphragm for sure.
Can you explain to us why it's published in Spanish? That's the most interesting part of that story. Wow.
I think it's in Spanish. I think Joaquin Guia is the author of the study. Yeah.
Great. Any other questions from the audience? Yes, microphone over there, please. Second row in...
So Dr. Takala before asked the panel one simple question. I will try to follow his steps. And now, presumably, I'm the manager of the hospital, and I'd like to know why it is important for the organization to invest in this new technology for the hospital and for the patients. If you could give the answers to that question.
I can feel the direct stare on me at this moment, I can tell you. My answer would be quite simple. I would say, you know, I will, and that's what I've also done, I will use it for my research and I'll pay it from my research budget.
Anybody else want to make a comment about that? And then we'll finish up.
Well, I've been working in Yuka's unit, so I can't say anything else.
Wait, but you're not working there now.
Not anymore, that's right. No, but basically I agree. We talked about the outcome studies, and that's what we are waiting for. I mean, that was Yuka's question before. Why the hell should we use NAVA? To me, it comes back to a little bit the same question, why the hell should we use a pulmonary catheter? That's mainly because we need monitoring. We need monitoring of the physiology, and for me, this NAVA catheter is just an excellent monitoring tool to actually understand what's going on and when to implement NAVA and when not. So I wouldn't have a good answer to my hospital administration, but for myself to use NAVA or to actually use the catheter, it's pretty clear. I want to see what's going on. I want to monitor the physiology. That's very simple.
The rest of the panel want to tackle that? No, you shouldn't. You were not asked.
Seriously, I think there is, again, to some point here. For us who developed this technology, we did it for a reason. It came back many years ago, like was actually me and Paolo Navalese and a bottle of grappa and some cigars. And it was because of a need. Everybody complained about the Synchrony. Everybody said it doesn't work. Now you have something that works, now you say, should we use it?
So wait a minute, I have a question for you, Christer. So you worked with Paolo Navalese is that how you got the name NAVA from the first 4 initials of his last name? Yeah? It's a good thing you weren't working with me at the time, because then you know what it would be called.
If I may come back seriously to your answer, first of all, my answer was serious. I mean, I am using NAVA practically only for research. I mean, we have a small usage for clinical reasons where we see clear problems of mismatch between drive and what we deliver from the ventilation. But I think the problem is at the moment is exactly that we have a fascinating technology. And as I said before, my greatest concern at the moment is that we spoil it. We must not spoil this technology. It's a unique technology. And therefore, before we run into a situation where we are investing 10% of our budget to NAVA, we better have the data to support that. But at the same time, we must be smart enough to get the funds so that we can support the further development of this technology. And of course, as long as we are working together with the industry, we must find ways where we get a win-win situation.
I read a book called Time. So who invented the watch? It was a guy in Bern. Sorry, not in Bern at the time, but Einstein was like the guy who really put time on the map. And before these clocks in Bern were synchronized to each other and showed the same time all the time, well, nobody cared about time. So at what time was the time to look at time? I mean, that's the same kind of, it's a circular discussion. I mean, it is an improvement. I think we all agree to that. There's an improvement of Synchrony. We don't know what Synchrony in itself have. We know that there are studies that have shown, as we were shown here, that you have prolonged time of mechanical ventilation, and there's a group of 25% of patients who suffer from this. Now, we use lower tidal volumes, so Synchrony is improved, but still, if there is an N of 1, shouldn't there be a way to do that? And I think the problem is to identify them, and I think Paolo said it himself. If I don't have the catheter, how do I know? It's a bit of a circular discussion.
I think we should take a break now because we only have 15 minutes, and actually this session goes on quite late. So I really think we need the coffee break. Let's come back at 5 o'clock. Yeah, and then do the last session.